much, and we are very appreciative of the APSC Cloud to initiate this webinar. Today's symposium is on decision-making in primary intervention therapy of acute coronary syndrome. A date stamp today is the 4th of November, 12 noon Singapore time. I'm very happy to have my co-chair, Professor Huang, the immediate past president of Taiwan TSOC, and he's going to co-chair and lead the discussion later on as well. Just a preamble to this session 1 of therapy of ACS. ACS presenting as either STEMI or NSTEMI remains as the main cause of cardiovascular catastrophic events, particularly mortality. Therefore, decision-making and acute management of STEMI and NSTEMIs needs to be quick as well as precise, including early thrombolysis or PCI in STEMI, culprit only, complete or partial revascularization of PCI in STEMIs, early or delayed PCI in NSTEMI, not to mention complications of cardiogenic shock that leads to mortality on top of cardiac arrest. On the other hand, we know the peculiarities of STEMI as well as a high thrombus burden in COVID-19 patients during this pandemic, the uniqueness of ACS in the young as well as the repercussions from studies such as courage and ischemia and stable CAD that re-emphasizes the role of optimal medical therapy over and beyond intervention, which we can all discuss in this very exciting critical topics in decision-making for ACS as well as stable coronary artery disease. I'm just going to introduce our esteemed speakers. Our first speaker is Dr. Chai from Thailand. He's a lecturer and interventional cardiologist at the King Chulalongkorn Memorial Hospital in Bangkok, Thailand. He's going to speak to us on primary thrombolysis, or primary PCI, or hybrid for acute STEMI, keys to the decision making. This will be followed by Professor Tan Hui Chim's talk. Professor Tan is the director for the NUHS National Heart Center and Singapore. And he's going to speak to us on culprit only or complete revascularization for primary PCI of acute STEMI with multivessel disease. He's also going to give us some keys to decision making. This will be followed by Professor Li Yi-heng from the National Cheung Kung University College of Medicine in Tainan, as well as he's a senior cardiologist there as well, the current president of the Taiwan Society of Lipids and Atherosclerosis. He's going to speak to us on delayed or early PCI for acute non-STEMI with critical ischemia, again, keys to decision-making tips. Last but not least, we have Dr. Sri Kim Lam, the consultant director of Cath Lab at the Pamela Yongde North Seoul Eastern Hospital from Hong Kong. He's going to speak to us on specific therapeutic strategies for acute AMI during the COVID-19 pandemic. How do we decide on who and how to treat COVID-19 patients during this period? So without further ado, I'm going to stop share and call upon our first speaker, Dr. Chai from Thailand, to give his first talk. Primary thrombolysis or primary PCI or hybrid therapy for acute STEMI. Thank you, Dr. Chai.
Okay, good afternoon, Mr. Chairman, co-chairman, all professors, ladies and gentlemen. My name is Chaisri Walapakorn from King Chulalongkorn Memorial Hospital, Thailand. Thank you to APSC for inviting me. Today, I'm going to talk about the treatment in acute STEMI, thrombolysis versus primary PCI. This is my disclosure slide. The first thing I would like to emphasize is time is muscle. The longer we delay, the bigger infarction. Once the cells are dead, they become scars, and the heart will never work as well again. In this slide, you can see the relationship between door to leader time and prognosis. This study is a 15-year registry of STEMI patients who treated with thrombolysis. Shorter door to needle time results in less mortality. about 15 to 30 minutes reduction in door to needle time reduce mortality by 1%. Primary PCI is quite the same. Longer door to balloon time becomes more mortality. If the door to balloon time is less than 45 minutes, the mortality rate is around 4 to 5%. But if the door to balloon time is over 90 minutes, the 1-year mortality is nearly 18%, 4 times compared to the first group. According to 2017 AAC guidelines, the reperfusion strategy depends on the FMC. If the FMC is a PCI center, of course, a primary PCI must be the treatment of choice. But if the FMC is a non-PCI center, the strategy should be selected by time to PCI. If time to PCI is less than 120 minutes, referring for a primary PCI should be done. But if it takes more than 120 minutes, thrombolysis should be given without delay. Actually, we have our own Thai ACS guideline, and it's quite the same as EAC guideline. So in summary, primary PCI is preferred to thrombolysis when it can be performed by skilled interventionists in a timely manner. The DYNAMIC 2 trial was an RCT assigned 1,500 patients with acute STEMI to treatment with primary PCI or thrombolysis with intravenous altiplase. The primary outcome was a composite of death, myocardial infarction, or stroke at 30 days of follow-up. This study showed primary PCI was superior to thrombolysis in combined group and in both transfer size and non-transfer size. The rate of the primary outcome was driven by the reduction in rate of recurrent myocardial infarction, as you seen in this slide, and the rate of mortality and stroke in primary PCI group were also less than in thrombolysis group, but no statistical significance. Not only the DYNAMIC 2 trial, but there are more than 20 RCT that show the superiority of primary PCI. This meta-analysis revealed both short-term and long-term outcome of primary PCI compared to thrombolysis. Primary PCI was superior to thrombolysis in almost all outcomes, include short-term mortality and also long-term mortality. So we can conclude that primary PCI is superior to thrombolysis, but not for all. As I emphasized on my first slide, the key of reperfusion is time. Time is muscle. Primary PCI is superior to thrombolysis when it is performed in a timely manner. STREAM trial is an RCT include nearly 1,900 patients. All of them were early presenters who presented within 2 hours after symptom onset and unable to undergo primary PCI within 1 hour. The study participants were assigned to treatment with TNK or primary PCI. The total ischemic time in the TNK group was about 100 minutes, whereas the total ischemic time in the primary PCI group was about 178 minutes. The difference of total ischemic time between both groups was 78 minutes. The primary outcome was a composite of death, myocardial infarction, shock, or heart failure at 30 days of follow-up. The primary outcome occurred in 12.4% in the TNK group and 14.3% in the primary PCI group. TNK seemed to be superior to primary PCI, but there was no statistical significance. The p-value was 0.24. And there was no statistically significant difference between the TNK group and primary PCI group in all secondary outcomes, which were all-cause death, cardiac death, heart failure, shock, and reinfarction. And in subgroup analysis, there was a trend that TNK may be superior to primary PCI in patients with acute inflammatory STEMI. So the conclusion from STREAM is that in patients with early STEMI who could not undergo primary PCI within 1 hour, thrombolysis is an effective reperfusion strategy when it is compared to primary PCI. But one thing you have to realize is about 1/3 of patients in TNK group need rescue PCI because of failed thrombolysis. Actually, not only STREAM trial, but also PRAC-2, CAP team, and Vienna give us the same information about in early STEMI patients that thrombolysis is an effective reperfusion strategy compared to primary PCI. You can see in this graph that the black box is the thrombolysis group. In early presented patients, the efficacy of the primary PCI compared to thrombolysis is about the same. But in some trials, such as CAP team or Vienna, in early presenter, thrombolysis may be superior to primary PCI, but only early presenter. And then which thrombolytic drugs should be given? A systemic review of several RCT comparing several regimens of thrombolytic drugs in patients with STEMI show that alteplase, tenecteplase, and reteplase should be considered over streptokinase in terms of both the safety, the major bleeding, and the efficacy about the mortality. And parenteral anticoagulant should be given together with thrombolysis to prevent reocclusion. So thrombolysis is an effective treatment, especially in early presenter STEMI patients. And fibrin-specific thrombolysis should be preferred. As I mentioned before, that rescue PCI is indicated in case of failed thrombolysis. Maybe 1/4 to 1/3 of patients who treat with thrombolysis fail of thrombolysis. But in case of successful thrombolysis, a routine early coronary angiogram and maybe PCI are still indicated within 24 hours. I'm going to show you the Garcia 1 trial. This is an RCT, include about 500 patients with successful thrombolysis. They were randomly assigned to angiography within 24 hours or conservative approach. The composite primary outcome was death, MI, or ischemic-driven revascularization. And you can see that there was 56% of relative reduction in primary outcome in intervention group compared to conservative group. So routine coronary angiogram after successful thrombolysis is still indicated. And according to 2017 AC guideline, in early phase of STEMI, primary PCI or thrombolysis can be chosen, depends on time to PCI, as I said before. But for late presentation STEMI or EVO STEMI, especially after 12 hours of onset, primary PCI is the only recommended reperfusion strategy. I'm going to show you the late trial. Late trial is an RCT, includes STEMI patients between 6 to 24 hours from symptom onset. The study participants were assigned to treatment with intravenous altiplase or placebo. In patients with symptom onset less than 12 hours in this group, altiplase was superior to placebo in terms of mortality. But in late STEMI patients, which onset is less than 12 hours, altiplase group is not superior to placebo. And that is why the guidelines do not recommend thrombolysis for late STEMI more than 12 hours delay. But for primary PCI, it is quite different. This is BRAVE2 trial. BRAVE2 trial was an RCT, include STEMI patients presenting from 12 to 48 hours. The patients were randomized to primary PCI or conservative treatment. And the results show that primary PCI can reduce 4-year mortality by 45% compared to conservative treatment. So ladies and gentlemen, this is the summary. For acute STEMI patients, time is muscle. The key is time is muscle. And everyone needs reperfusion. Primary PCI is the treatment of choice if it can be performed in a timely manner. But if it cannot, thrombolysis is a good alternative treatment, especially in early presenter patients. Contraindication must be revealed before thrombolysis is given. Fibrin-specific drugs are preferred to streptokinase. And rescue PCI should be done as soon as possible in case of failed thrombolysis. And in case of successful thrombolysis, routine choreangiogram should be done within 24 hours. And last but not least, for late presentation STEMI patients, primary PCI is the treatment of choice. Thank you.
Thanks, Dr. Chai. Dr. Huang will lead the Q&A for this first talk. Dr. Chai,
okay.
Can I ask you to stop share your
sure.
slides? Prof. Huang,
okay, I think in Taiwan, because the primary PCI for STEMI patient, the case lab is quite easy available around the whole Taiwan. So I may ask the Professor Lee from the Cheng-Kung University Hospital to share our experience of primary PCI versus thrombolysis in treating the STEMI patient, even in the COVID-19 era. Okay, Professor Lee, and you will share our colleague in Taiwan, and what's the role of thrombolysis in treating STEMI patient in Taiwan?
Thank you, dear Professor Huang. As we know, maybe some large countries, just like in Thailand or like in China, for some places, they still need the intravenous thrombolysis for the STEMI. However, like a small country like in Taiwan or in Singapore or in Hong Kong, or even in Japan, I think most of the STEMI patients now receive the primary PCI as the reperfusion therapy. Just like the Professor Huang mentioned that even in Taiwan during the COVID-19 pandemic, because we don't have too much cases of COVID-19 here in Taiwan. So in hospitals, right now, we still use the primary PCI as the first line treatment for our STEMI patient. So in this year, compare with the same time duration as the last year, we have the dose to the device time right now is around about 60 minutes, the same in this year and compare with the last year. So there is no influence of the COVID-19 pandemic in Taiwan.
Thanks, Professor Lee.
Okay.
I thought I learned a lot from Dr. Chai's talk. Prof. Huang, can I ask some questions also of Dr. Chai? My observation about the talk was that thrombolysis is still extremely important in Asia because in most developing countries in Asia, thrombolysis is still the first choice therapy, and it forms a bulk of therapy, although it's less used in East Asian countries. It's still very heavily dependent in Southeast Asian countries. I also learned that thrombolysis is good if it's given very early post-STEMI, within the first 12 hours, but the evidence shows us PCI outperforms or the longer period as well as acutely as well. Can I ask about the DAP regime in Thailand, for example, if you are employing thrombolysis? What is the DAP regime and what is the opinion of facilitated PCI or facilitated PCI for places that's very far out from the main centers?
Okay. Actually, we divide the region in Thailand to be network to be district. If some hospital that close to the PCI center, they must be refer the patients to that center if the time to PCI is not more than 120 minutes. But in some hospital that in rural area, yes, we gave the thrombolysis, and the first line for us is still septokinase because of the reimbursement. But we try to give TNK more. And about in case that we give the thrombolysis, if the referral hospital they available for the patient, then the non-PCI center will refer the patient to the referral hospital.
Do they give DAPT loading as well?
Yes, yes, of course. They give for the thrombolysis patient, they give aspirin and clopidogrel.
Is there any patients who are switched to ticagrelor or prasugrel post thrombolysis?
If for thrombolysis, no. For thrombolysis, we give only clopidogrel.
Thank you.
And I'm curious about the quality of care in primary PCI in Thailand. So any qualification or comparing the total device time in different hospitals in Thailand right now?
Actually, in our center, we record the time to PCI in every case. If the patients come to our emergency department, not the refer case, in our case, the time to PCI from the diagnosis to Y crossing time is less than 60 minutes in our center. But I don't have the data from the other hospital.
In Taiwan, right now, the policy of the total development time in treating STEMI patient is in the hospital accreditation policy. If the hospital do not shorten the total development time or total wire time less than 90 minutes, the hospital could not be qualified to be a medical center. So that's an effort of hospital. So every hospital, right now in Taiwan, there are 19 medical centers in Taiwan. So all the hospitals should be shortened the total device time less than 90 minutes.
That's great. Dr. Sri, you want to share the experience in Hong Kong?
Right. So as mentioned again, we targeted as a primary PCI as the predominant strategy, but also as discussed, we cannot achieve primary PCI for all patients. So for those patients who cannot achieve primary PCI, if we talk about the depth as raised by Jacqueline, we will give aspirin and clopidogrel with the TNK, and we use TNK for this group of patients. But then usually after pharmacoinvasive treatment, that means after PCI, then usually we will shift to ticagrelor. That is our usual practice.
Thanks, Dr. Sri. Any other comments or addition before we close out the Q&A for this first session?
And could I ask Professor Huang then? It's very interested to hear that for those centers who has long door-to-device time, you disqualify them, right? So I would like to ask a logistic issue. So who do the audit for the door-to-device time? Is it self-reported, or there is an authority who do the audit regularly?
In Taiwan, because
Yeah.
we have government-supported hospital accreditation system, so they will recruit the professional members to audit on-site visit each hospital. So they should report it and just draw the sample cases and go to detail case by case. For example, just draw the 20 cases, and at least you should have the more than 80%. More than 80% should be door-to-device time less than 90 minutes. So I'm also one of the audit professional members. So we are just this system. So external audit for each medical center.
Right. Oh, so that is a good system. And good to know you have a cutoff of 80% cases, because that is the next question I'm about to ask. Because we know that the medium door-to-device time may be very good. So for example, for our center, it's also about 60-something minutes. But if you look at the range, it is very wide. Some patients, the door-to-device time is very long for various reasons. So in your system, you mandate 80% of cases within 90 minutes. So that's a very fair approach and good system.
Yeah, because we are through discussion, that's more reasonable. Because some patients presenting as chest pain, maybe the other diagnosis such as acute aortic dissection, acute aortic
yes,
pulmonary embolism should be delayed and more than 90 minutes. That's acceptable for 20%. So our rule right now, the regulation is more than 80% of patients, you should be door-to-device time less than 90 minutes.
Right.
So that's a fantastic question. It's a webinar by itself. How do you adjudicate primary events? And in Singapore, we have some criteria for system, non-system delay. You only analyze those cases that had system delays. And each hospital is mandated to employ staff to collect the data independently. So it's all audited, both for STEMI as well as NSTEMI. So it's actually a huge cost, but I think it helps improve standards, and it's good that Taiwan put it as a mandate for accreditation. I think that's one step forward so that people pay attention to it seriously. I think we have to move on to the second lecture. The second lecture will be a recording by Professor Tan Hui Chin from Singapore. He's going to move track a little bit from thrombolysis into culprit-only or complete revascularization for primary PCI in STEMI patients with multivessel disease, focusing on the decision-making tree in multivessel acute PCI. We can play the
Good morning.
talk
Thank you for the invitation to participate.
One moment, we have some technical problem.
So we're playing the lecture now?
Yeah, we are going to play.
Yeah, sure.
Everybody see it? Okay.
Yeah.
We play now.
APSC Cloud Forum of CV Disease. And the topic that I'm talking about today is culprit-only versus complete revascularizations for primary PCI therapy of acute STEMI patients with multivessel coronary artery disease.
is it possible to make
I
it full
thought
screen?
we should begin the discussions of the topic by sharing a case example. This is a 40-year-old Chinese male with cardiovascular risk factor of smoking and family history of coronary artery disease, and came in with sudden chest pain.
That's good.
And clearly we can see that is ST segment elevation in the high lateral leads of 1 and AVR with corresponding reciprocal ST segment depression in the inferior leads. And this is the angiogram of his. You can see that actually there is a evidence of a proximal LAD disease, but that is not the culprit. The culprit is actually an occluded diagonal artery. But clearly patient has also underlying coronary artery disease involving the proximal LAD as well as the mid LAD segment. So the decisions by the operator was to go ahead and fix the culprit lesion first and bring in a stent 2.5 by 23 millimeter in the diagonal and opening up the diagonal culprit vessel, and then now facing with this issues here of residual stenosis in the osteo as well as the proximal LAD artery. Now this is the left coronary artery. On the right side of the patients who we did the angiogram as well, again there was another discrete stenosis at the segment. So the question now for the operator in this setting of acute ST elevations myocardial infarction is what should he do? And what would you do as well? So would you just treat the culprit vessel only and then just leave the rest alone? Or you would go ahead and do a multi-vessel PCI in this setting as well of the RCA as well as the LAD stenosis? Or would you choose to do a stage PCI, but this stage PCI is done during index hospitalization? And finally, would you do a stage PCI after the patient has been discharged and to be coming back as an elective procedure? Now, we know from the background of patients with multivascular coronary artery disease is that it occurs in about 50% of patients who undergoes primary PCI for ST elevations myocardial infarction. In fact, the presence of a multivessel CAD portends a worse outcomes compared to patients with single vessel disease. And the multivessel PCI in the primary PCI setting was first pioneered by Dr. Jeff Hassler. And he actually at that time recommended early staging of PCI, and that was in the era of balloon angioplasty, and not to attempt the multivessel PCI at the same time during AMI. And we also know from the early study that when somebody manifests silent ischemia after acute myocardial infarction, this is bad outcome. This is associated with cardiac death, major adverse cardiac events, especially in untreated patients as reported in the Swiss C2 trial way back in 2007. And we also know that when you have multivascular coronary artery disease, it is possible that these patients may have multiple unstable plugs in the rest of the coronary vasculature. We know from a prospect trial, we know from Goldstein and STEMI trial, and a variety of angioscopic and ultrasonographic studies. So in this area of primary PCI, should then all the non-infarct lesions be revascularized? We know that even in the setting of primary PCI, STEMI does have a high early morbidity and mortality can be as high as 10% in some of the series. But we also know that complete revascularization is always better than partial revascularization as it improves the outcomes in patients with multivessel coronary artery disease. But the questions to be answered is, does the impact of the STEMI pathophysiology is there a significant impact of the STEMI pathophysiology on the non-culprit vessel plaque? And secondly, does treatment of the non-culprit plaque alters the natural history of coronary artery disease in this group of patients presenting with STEMI and resulting in clinical benefit? For those people who argue for only culprit-only PCI strategy and not do a multivessel PCI, argues that, when you have a patients with AMI, the ischemia and complications in even the non-infarct related artery is usually very poorly tolerated. You just added on to additional injury to the patient's heart muscles. So there is potential for hemodynamic and electrophysiologic instability should any complications arise. Those who argue against doing multivessel lesion is that the increased amount of contrast use, particularly when we don't know the patient's presenting renal status, can result in contrast-induced nephropathy. And also the milieu of the STEMI may be against doing a more extensive PCI. The systemic vasoconstrictions, the endothelial dysfunctions may lead to an overestimation of a non-infarct related artery lesion severity, leading to an undersizing of stent. Also, when you have a suboptimal reperfusion results of infarct artery, the heavy thrombotic burden, all this adds to a very thrombotic milieu in the patients with STEMI, plus the platelet activation, pro-thrombotic state, and increase, leading to an increased risk of stent thrombosis. However, the group of people who argues for multivessel PCI will tell you that AMI is a generalized pathophysiological derangement of endothelial dysfunction, and that it has the potential to impair coronary perfusion beyond the corporate lesion distribution and destabilize the plaques throughout the coronary vasculature. And there's actually no better time than present, especially when patients already present himself. So there are benefits from a patient factors perspective because he's a captive audience. He's already on the table. He's already on the maximal antithrombotic therapy. And you wouldn't have a situations where the patient is lost to follow-up and don't come back for you for further treatment. There are also clinical benefits. There is a potential for improved hemodynamics if you do the non-infarct related artery PCI. You reduce ischemia, you prevent reinfarction, and you actually have passivate the vessel somewhat with this mechanical treatment. Also, from a system of care perspective, from the healthcare perspective, perhaps you now have fewer hospitalizations, fewer procedure, you just do it one shot, and that might lead to a decrease in terms of a total cost of healthcare. So when we look at the data in the early days, and particularly in the balloon angioplasty and bare metal stent era, we get very conflicting results with regard to the benefits of multivessel versus corporate lesion only PCI during STEMI. In this reported various series, you can see that in patients with the green bar of multivessel PCI, they might have an increased 1-year mortality if you attempt the multi-lesion, or you actually have no difference as far as the outcomes of 1-year mortality compared to just corporate lesions. So largely was not very positive, but yet we also have positive meta-analysis and review reported. Again, this is 2014. And looking at the data here, you find that from a long-term mortality perspective in patients with corporate only versus complete revascularizations, there might be a trend towards a benefit in those who receive multivessel PCI. But really the benefit of multivessel PCI is when you do it as a stage setting, when you do it either as a stage within the index hospitalizations a couple of days later, or you do it as a stage procedure, as an elective outpatient procedure. This is where you see the significant benefit of a multivessel PCI. But many of these studies, unfortunately, were just retrospective registry study, and they were not randomized controlled trial. Fortunately, in the early 2013 and 2015, we do have, in one shot, in a very short period of time, 3 randomized controlled trials in patients with STEMI undergoing either corporate lesions PCI or a multivessel PCI. So primary, corporate, and multi-dynamic study was something that we were all very familiar with, but there are actually differences in terms of the design of these 3 different studies. For example, in primary, they rely on the angiographic assessment of the non-infarct related artery lesions. Anything more than 50% is considered significant, whereas in pre-multi, they will look at 50% stenosis, but will have to have a FFR of less than 0.8 to qualify for a significant lesion. But if the lesion is more than 90% stenosis, then it's considered as just significant without the need for a FFR. All of this strategy in these 3 different trials compare against a conservative care where only the primary corporate lesions is treated. So let's look at the endpoint, which are a little bit different. But from the endpoint here, you can see that all the 3 trials do favor the strategy of a multivessel percutaneous coronary intervention in patients with STEMI. So picking up corporate trial, because it's probably the second trial, and primary trial was just too small a trial to really talk about. But when we look at the corporate trial and looking at the composite of total mortality recurrent myocardial infarction, heart failure, and ischemia-driven revascularization at 12 months, clearly you can see that the patients who were randomized to the complete revascularization arm has a much better MACE at 1 year of follow-up. And when we look at the 5-year follow-up of corporate trial, you find that this benefit continues to persist even up to 5 years of follow-up. And the benefit here is significant. It is significant because it pertains to a hard clinical endpoints of death and myocardial infarction, not recurrent angina, not repeat revascularizations. So at 5 years, you can see that the difference was 10% versus 18.5%, which was clearly statistically significant.
I think
sorry, we lost a signal. Now we come back. Can we carry on?
Yep.
Sorry.
Yeah, let's please carry on from where we left off. I think we are in the exciting part of Hui Chin's lecture.
Okay, we will backward a few minutes. All right, okay?
Yeah, okay.
We are back. Okay?
So picking up corporate trial, because it's probably the second trial, and primary trial was just too small a trial to really talk about. But when we look at the corporate trial and looking at the composite of total mortality, recurrent myocardial infarction, heart failure, and ischemia-driven revascularization at 12 months, clearly you can see that the patients who were randomized to the complete revascularization arm has a much better MACE at 1 year of follow-up. And when we look at the 5-year follow-up of corporate trial, you find that this benefit continues to persist even up to 5 years of follow-up. And the benefit here is significant. It is significant because it pertains to a hard clinical endpoints of death and myocardial infarction, not recurrent angina, not repeat revascularizations. So at 5 years, you can see that the difference was 10% versus 18.5%, which was clearly statistically significant. And majority of the benefit actually occur in the early phase rather than the late phase during a long-term follow-up. So in this landmark analysis, beyond 1 year to 5 years, it's actually not much of a difference. So most of the benefit will actually happening within the first 1 year of a patient's treatment. I also want to comment on Dynamic Primality trial, because the strategy here actually involves a functional assessment, which is the use of FFR to guide therapy. In Dynamic Primality trial, we know that the use of FFR-guided revascularization in patients with multivessel disease brought about a significant 69% reduction in the need for repeat revascularizations. So this is repeat revascularization, but no significant difference was seen in hard clinical endpoints of cardiac death. Now, Dynamic Primality uses FFR, and actually Compare Acute, which is the later trial, also uses a physiologic functional assessment to guide multivessel PCI. Compare Acute also adopt a strategy of FFR-guided PCI and also show the same benefit. There was a significant reduction in MACE driven by a reduction in the need for revascularizations. So for those patients who have more than 50% stenosis, FFR more than 0.8, it is very safe to actually defer treatment of this lesion, and it's also obviously efficient and cost saving. So Compare Acute do reinforce the physiologic approach benefit. And when we use the FFR to assess a patient's non-culprit coronary artery stenosis in the setting of STEMI, actually it is quite predictable and quite useful as well. In this particular study where FFR was done acutely in the non-infarct-related artery lesion, and then compared with the 1 month later, a repeat FFR done, actually the FFR do not change much. So FFR values of non-culprit stenosis do not change between the acute and follow-up. So you could actually, in the acute setting, do a FFR assessment. This is unlike that of a culprit lesions in the STEMI where the values may not be as accurate. So I also want to touch on the final trial of culprit versus complete revascularizations because of this complete trial, as it's aptly named. Complete trial is important because it's the single largest randomized control trial of 4,441. All the other trials have under 1,000 patients enrolled. Now, complete trial looks at 2 primary outcomes. First primary outcome, hard endpoints here of cardiovascular death or myocardial infarction. A second co-primary outcome is death, myocardial infarction, and ischemia-driven revascularizations. And you can clearly see that in the first 1 year, up to 5 years of follow-up with a median follow-up of 3 years, there was a clear separation of curve here. There was a clear reduction in the heart clinical endpoints in those patients that had multivessel PCI versus culprit lesions treatment. However, complete trials revascularization strategy for the non-culprit lesions is a little bit different from the rest. It did not ask for an immediate in-hospital revascularization or even during the index procedure itself. It actually allows for the patient to be discharged and have the revascularization done within 45 days. So whether it's done during index hospitalization or whether the patient has been discharged and then come back again within 45 days, the benefits of complete revascularization over culprit lesions continue to be present and consistent. So the benefit of heart clinical endpoints emerge mainly over the long term, and it doesn't matter whether the patient had a PCI of the non-culprit lesions done during hospitalizations or during follow-up as an outpatient. So when we look at all the trials, particularly these 5 clinical trials, looking at their endpoints, primary endpoints here, you can see that all of which do suggest that there is a significant reduction in terms of death and myocardial infarction, and some has got a reduction in the ischemia-driven revascularization. So to put all these 5 trials together in a meta-analysis reported in this particular paper in JACC 2020 this year, we find that when you have a multivessel PCI compared with a culprit lesions PCI, there is no significant difference in all-cause mortality, but there is significant difference in the lowering of the risk for reinfarction, cardiac mortality, and repeat revascularization. So reinfarction, cardiovascular mortality, repeat revascularizations, these are very important outcomes for practicing interventionists. But there's no difference in major bleeding, stroke, and contrast-induced nephropathy despite the additional procedures being performed. So the other points that we need to talk about here is, so is angiographic assessment good enough, or do we have to do a FFR as in the Primalti trial or in the Compare Acute study? So when we look at this particular study, looking at all the FFR guided study versus those who have angiographic assessment of the non-culprit lesions, you find that the FFR study actually has got no significant benefit in terms of heart clinical endpoints, whereas the angiography actually approach has got a better outcomes compared to the FFR guided. So we know that FFR predicts flow severity and subsequent ischemia-driven revascularization. FAME1 tells us that. But we also know from the other study that by angiographic assessment, some of this moderate stenosis may, or even severe stenosis, may select out complex lesions and vulnerability as well. Prospect trial tells us that majority or at least half of the events that occurred in the patients presenting with ACS a couple of 3 years later actually occurs in the non-culprit lesions. Perhaps we need something else more than FFR. Perhaps we need something else more than angiography to help us decide. And so now we have this whole concept here of a trifecta, where you want to identify a high-risk lesions called the triple LLL lesions that can predict the poor clinical cardiovascular outcomes. So what are these 3L? You will be people with large plaque size of more than 70%, lipid-rich core, and lumen area of less than 4 square millimeter. So when you have these 3 features in the coronary plaque, it predicts poor outcomes from the earlier Prospect 1 as well as the Prospect 2 trial. So we know that from the various intravascular imaging that we have now IVUS is good in terms of predicting plaque size. We could have IVUS histology that will tell us, virtual histology can tell us the vulnerability of the plaque with regard to lipid core. Now we have NIRS and OCT that can also tell us the lipid content of the lesion. And better still, OCT can also measure the fibrous cap thickness and indicative of the vulnerability of the plaque. So we also know that now from the Absorb Prospect, which you just presented at TCT Connect this year, it is possible to alter a natural history of the coronary disease with a mechanical strategy, and in this particular trial, using a bioresorbable scaffold. And they have shown that particularly from the effectiveness endpoint, there was a larger minimal lumen area at 25 months of follow-up in the group that had bioresorbable scaffold implanted versus those who were just treated medically. but from a safety endpoint, target lesion failure, they didn't show a statistical difference, but you can clearly see that the patients who receive scaffold actually have a lower incidence trended of 4.3% versus 10.7%. So identification of vulnerable plaques in the patients with STEMI, followed by some form of intervention or some other therapy, may perhaps alter the outcome of the natural history of a patient's disease. So what is also awaiting, we are eagerly awaiting is, of course, the prime time trial, because prime time trial is going to randomize patients with STEMI and multivascular coronary artery disease into two strategies now, comparing FFR guided group versus an angiography guided group. And we certainly want to see whether these approaches do have a significant impact on the heart clinical endpoints of death and myocardial infarctions at 12 months. So let's look at the international guidelines with regard to this particular issue. When we look at the ACCF and AHA guidelines 2013, it was a class 3 to be doing a non-infarct artery at the time of primary PCI. But by 2015, they have upgraded it into a 2B, where the evidence might be slightly better, but still not abrogated. When we look at the European guidelines 2018 on myocardial revascularization, they even upgraded it to a 2A. So a routine revascularization of a non-IRA lesions should be considered in STEMI patients with multivascular disease before hospital discharge. So what did I do for my patients? So these patients had a concurrent RCA disease. I decided to do an FFR. So the FFR measure was 0.89. So no need to do anything. This patient has got a residual disease in the LAD. So I did an FFR at the time of the primary PCI when he came in with STEMI, but it was measured to be 0.76. So I brought him back 2 weeks later, and I repeat the FFR again. I repeat the FFR in the right coronary artery. It was 0.84 compared to 0.89, pretty close, so still hemodynamically not significant. I repeat the FFR. It is exactly the same, 0.76 2 weeks later compared to 2 weeks ago. So I then proceed on to do a stage PCI of the LAD stenosis. There were 2 of them in the LAD. It was 0.76 pre-PCI, and it was 0.89 post-PCI. So in conclusion, I have a certain perspective here. I think following a patient's discharge, how do we assess the rest of the other non-culprit lesions? Do we talk about the non-culprit lesions being CTO? Do we treat them the same as a non-CTO lesion? How do we stratify for evidence of ischemia? Is FFR good enough, or should we be doing FFR followed by OCT or FFR followed by IVUS to better characterize the lesions? And certainly when patients has got comorbidity, they all have to be factored in the final decisions to do whether multivascular PCI or corporate lesions PCI. So the conclusion here is that complete revascularization should not be routinely performed ad hoc, in my opinion, but based on the individual and careful patients and lesion assessment, we could always stage it on another occasions. With that, thank you very much for your attention. I wish the meeting every success.
Thanks, Richim. And we welcome Richim to join in now.
Thank you very much.
Yeah, thanks. It was an excellent review lecture. I really enjoyed it. I have lots of questions, but I defer to the rest first. Any questions from the panel for Richim?
Yeah, in Singapore, right now, the most cardiologists will perform capillary lesion only PCI or complete revascularization. Could you share us the current practice? In Taiwan, most doctors, I think, is capillary lesion only primary PCI.
It is true that we perform corporate lesions during the STEMI primary PCI. There are only a few occasions that you will intervene in the non-infarct related artery. One is, of course, a clearly tight lesion that is hemodynamically significant, impairing blood flow. Then you will consider and just go ahead and fix it. It's not too difficult to do. But for the most part, most of us will leave the non-culprit lesions aside. If the patient is considered a low-risk patient, we may do the rest of the lesions during the hospitalization. But if this is a large AMI and heart failure and arrhythmia, then we might let him stabilize, come back within a month to do the rest of the other lesions. So I think stage procedure is the key. Most nobody do multivessel lesion treatment during the index procedure.
How about the situation in Thailand?
Yes, it's quite the same that we do only the culprit lesion when we do the primary PCI, and most of the case we do the non-culprit lesion for the stage PCI maybe within 3 to 4 weeks.
In Taiwan, maybe the majority of cardiologists will perform the lung culprit lesion PCI during the same admission duration, maybe before discharge. But some doctors prefer perform the lung culprit lesion PCI maybe 2 weeks or within 1 month, stage PCI.
There's no right or wrong answer here. I think a complete trial tells us that you can do it in hospital or you can do it anytime within 45 days of post-discharge.
So, Hui-Chim, I have a question. Based on the evidence you presented, it seems as if people are advocating index in hospital, stage, and maybe up to 40 days stage. All seems fairly reasonable approach based on individualized approach. I want to ask you then, is there any role now for intermediate non-invasive risk stratification, or should all patients come back to the lab again?
I think from a system perspective and from a patient perspective, I would actually like to assess the non-culprit lesions or at the same time during the index procedure so that the patient does not have to come back again for a non-invasive nerves with questions that need to be answered. So if I see an intermediate lesions, I will just go ahead and do a FFR in a non-infarct related artery at the end of the procedure so that I will have an idea to tell the patients what to do next. So I think from a system perspective and efficiency standpoint, I feel that the functional assessment of the non-infarct related lesion is a very cost and time effective strategy.
With FFR or IFR, no?
I use FFR mostly. I'm not sure about IFR in the setting of a STEMI procedure.
Any other comments from the panel? Or any questions?
You do the Jack in your practice?
Me, I always stage. And I stage usually within 2 weeks. I actually don't do non-culprit FFR during the index procedure because it still adds on to extra dye, and I think there are a lot of things that's not quite sorted out or figured out during the acute setting. And I just fix the culprit, make it simple and straightforward as much as possible, and then bring the patient back. Usually not inpatient, but usually a stage, unless a non-culprit lesion is really very tight. So either then index or inpatient stage. That is kind of my practice at the moment.
And it's based on angiographic assessment of the non-culprit lesions, I suppose.
Yes.
Non-invasive.
Yeah, and I think although the studies does show that index FFR non-culprit seems to work quite well, I think I still prefer them fairly stable, optimize the medical therapy, then do the FFR.
Yeah, there's a problem with FFR as well. We also know that in lesions 75% and above, there are about 25% of patients who FFR will tell you that it's not hemodynamically significant. So whether it's safe to just leave these tight lesions alone with a negative FFR, we still don't know, because prospect trial tells us that the heavy plaque burden is a predictor of future events. So I feel that maybe in future we might have to do a FFR plus sort of investigation. We obviously will add on to the course, do FFR plus OCT or IVUS to see the vulnerability of the plaque as well.
That part maybe I can ask you and the rest of the panel. You presented on prospect the 3L concept. How do you really apply the 3L concept? Is it really validated enough for you to do OCT IVUS to treat maybe what you identify as vulnerable plaques at the moment?
It has not changed my practice yet. I just need more data. I need more understanding of this approach before I start pulling out OCT and IVUS on the non-carotid lesions. I feel that if the FFR shows that it's not hemodynamically significant, I'm not in a great, I'm not in a great hurry to actually intervene in the non-carotid lesions. I feel that I do have time to consider some course of medical intervention, like lipid lowering and so forth, at least pull the plug and let me assess on another occasion. So it has not changed my practice yet, but I'm obviously following this part of it very closely.
Thanks, Prof. Tan. Any other questions from the panel? If not, I think I learned a lot from Richim's lecture. I think it did change practice in some ways. I think the guidelines reflect that, either 2B or 2A, to have invasive guided PCI of the non-corporate vessel early. Early is up to you to define based on patient characteristics, from index up to a stage procedure. Looking at the event rate curves, I'm still wary about delaying it too late. Up to 40 days seems pretty long to me. So I think within reason, less than a month seems more reasonable if you ask me, all the way down to index. Sorry, all the way down to inpatient. I'm still not certain about index procedure multi-vessel PCI for STEMI. So with that, I think we should move on to the next lecture. Thanks for joining us, Richim. So Prof. Li Heng is going to talk to us next on early or delayed PCI for acute and STEMI with critical ischemia. Again, some keys to decision making. Thanks, Li Heng.
Professor Lee, you should turn on your sound.
Okay. Thanks for APSC for inviting me to this exciting meeting. The topic assigned to me is to discuss about the early or delayed PCI for non-STEMI with critical ischemia. And I will specifically talk about the keys to the decision making about the timing for PCI in patient with non-STEMI. This is my disclosure. So personally, I think there are several very important considerations when we make decision for the timing of PCI for non-STEMI. As we know that the patients with non-STEMI actually is a very heterogeneous group. So we have to make decision to select some very high-risk patient to receive the earlier PCI or early coronary angiography. So personally, I think there are several points are very, very important. The first one is the patient's clinical symptom signs after the initial medical treatment for the non-STEMI. And the second one, and I think it's also very important, is the patient's ECG manifestation, and also in the follow-up ECG manifestation. And probably image study with echocardiography could be helpful for the our decision making. So for the patient's clinical symptom and the signs, we have to be very, very careful. The first one is the patient's vital signs. For all those patients with non-STEMI admission to the coronary CCU or ICU, the patient have to receive continuous monitoring of their hemodynamic conditions. We have to watch out for the appearance of any hemodynamic instability or any early signs of cardiogenic shock. If the patient do have any unstable hemodynamics, like the unstable blood pressure or any very early signs of heart failure of cardiogenic shock, that's one very important indicator that this patient should receive early PCI or early coronary angiography. And the second one is the patient's symptoms. In all those patients with non-STEMI that receive the initial medical treatment, that include the dual antiplatelet therapy, the IV heparin, and the IV nitroglycerin, and sometimes we also use the early use of the beta blocker if there is no contraindication. After all those initial medical treatment, if the patient still present with recurrent chest discomfort, or the patient has the refractory chest symptom despite all those medical treatment, that is also a very, very important indicator that we should perform early PCI for these patients. And the third one is the patient signs. During the during the acute stage of the non-STEMI, we must also be very careful to watch out for any signs suggesting the heart failure, the LV dysfunction, or any possibility of the mechanical complications of the acute myocardial infarction, like the new onset, new murmurs indicating of the acute mitral regurgitation, or any possibility of intraseptal rupture. So if there do have some early signs of any medical complication, an emergent echocardiography will be very, very helpful. So if patients do have these signs suggesting heart failure or mechanical complication, that's another very indicator that we should perform the early catheterization to define the coronary anatomy of this patient. So the first part, the first key that will be helpful for us to make the early decision for PCI, I think, including the symptoms, the patient's symptoms and the patient's signs, and especially the vital signs. And the second point I want to emphasize is the manifestation of ECG, including the follow-up ECG in patients with acute non-STEMI. So after the initial medical treatment, just I mentioned before, if the patient still have the persistent the STT change indicating the severe myocardial ischemia, or if the patient do have any other new dynamic changes of the STT on the ECG, that's also a very important indicator that we should perform early PCI in these patients. And the second point is if the ECG shows any transient ST elevation, we should do ECG, because probably all of us know that if the patient do have the persistent ST elevation, the patient should be treated as the STEMI. We use the primary PCI. In patients with initial presentation with non-STEMI, but during the follow-up ECG show any ST segment elevations, we should also treat this patient as the STEMI, and we should send the patient to cath lab as soon as possible. And the third point that we need to continuously monitor this patient is to look at any appearance of life-threatening arrhythmias, like the ventricular fibrillation, ventricular tachycardia. So if the patient have any lethal appearance of the lethal ventricular arrhythmias, we have to send the patient to cath lab and as soon as possible. And the fourth point, I think it's also very important for us, is that for some patient with the initial ECG manifestation without very prominent ST elevation, however, and usually this patient sometimes will be treated with as a non-STEMI. However, if the patient have the following ECG manifestation, we call them a STEMI equivalent, and also should send this patient to cath lab as soon as possible. I think there are two types of ECG manifestation we should treat as a STEMI equivalent. The first one is the posterior myocardial infarction. The typical ECG of the posterior myocardial infarction actually is a ST segment depression in a precordial lead, usually over V1 to V4, and with a very RS ratio greater than 1 in this V1 or V2. So sometimes the posterior MI is associated with inferior STEMI. However, sometimes there is a true posterior MI, and there's no ST elevation on the ECG, and this patient probably will be treated as non-STEMI. However, we know that sometimes the posterior MI, usually the coronary artery is usually the circumflex artery, and sometimes it's usually a very critical or even total occlusion of the circumflex artery. So if a patient with any suspect of the posterior myocardial infarction, we should treat them as a STEMI and send patient to cath lab as soon as possible. For example, in this ECG, the patient with typical chest symptoms, and we can see there are ST depression from the V2, V3, and the V4. And there is a RS ratio greater than 1 in V2 and the V3. So in this ECG, we should suspect the patient has a true posterior myocardial infarction. And actually, it is a STEMI, it's true posterior STEMI. And we should treat this patient as a STEMI and use the primary PCI. If you look more carefully in this ECG, actually you can see a very mild ST elevation in these 3 and the AVF. So probably this is a patient with inferior MI and the extension to the posterior wall. So how can we to define the true posterior MI with ECG? That's we should do the ECG with V7, V8, and V9. And in this case, if you put the lead in the back, in the V7 to V9, you can see the ST elevation in the here and here. That's the true posterior MI. And the location of the V7 and V9 is here. The V7 is placed at the same level of V6 and in the posterior axillary line. And the V8 is in the left side of the back and in the tip of our scapular bone. And the lead V9 is placed in the left paraspinal region at the same level as V6. I know these leads, we do not routinely perform these leads. However, in order to detect a true posterior MI, sometimes we still need the V7 to V9 because the true posterior MI, and very often it was treated as a non-ST elevation MI. Another condition I think is also very important is a left main MI or left main critical lesion. Usually the ECG manifestation is the ST elevation in lead AVR and in lead V1. And usually the ST elevation in AVR is higher than lead V1. And there will be ST depression in lead 1, 2, and in the precordial leads. Because in left main lesion, usually the ST depression will be more prominent than the ST elevation in the AVR. So very often, these patients are all treated as non-STEMI. However, if you look at the ECG more carefully, there is a ST elevation in lead AVR. You must think of the left main lesion, and this patient should send for cath lab as soon as possible for PCI. For example, in this case, you can see the ECG here. There's a very prominent ST depression in the precordial lead here from V3 all the way to V6. And there's also ST depression in lead 1, lead 2, and AVL here. But the most important points here, you can see there is ST elevation in AVR and also in V1. You can see the ST elevation here in AVR is higher than that here in V1. So in this case, even you diagnose the patient as a non-STEMI, however, you know the lesion is probably in the left main, and then this patient should to the cath lab for very early PCI. This is another case. You can see the ECG here with very, very prominent ST depression in the precordial lead from V2 to V6, and also in 1, 2, and the AVA. So there is very extensive ST depression. But the most important points here, you can see the ST elevation in the AVR. So in this case, it's also a left main disease. So in this patient, we should also send them to cath lab as fast as we can. So that's the summary about the key steps, the keys to the decision making for the early PCI. So this is from the 2020 European guideline of the non-ST elevation ACS. You can see here, as I mentioned before, if the patient has a hemodynamic unstable or any signs of cardiogenic shock, and the patient have refractory or recurrent chest pain despite the medical treatment, any appearance of life-threatening arrhythmia, any signs of medical complication, any signs of indicating of the heart failure, all these patients are at very, very high risk, and the patient should send for the cath lab usually within 2 hours. That's the suggestion from the European guideline. So that means we should treat all these patients probably as the STEMI. And the final point here indicating the left main disease, that is the ST depression over 6 Ds and the ST elevation in AVR and or V1. So here, the 6 point here indicate the left main disease. So in European guideline, all these patients should be treated as the in very, very early PCI, just like we treat the STEMI. For the other patient, like the patient with definite diagnosis of non-STEMI with the very prominent elevation of cardiac marker, or the patient with very evident the myocardial ischemia change on the ECG, like the dynamic STT change or the persistent new STT change, all of them indicating the ongoing ischemia, or the transient appearance, the ST elevation. For all these patients should also receive the early PCI. And the European guideline here suggests usually within 24 hours. In my personal point of view, for all those patients, like here with unstable hemodynamics or with any signs of heart failure or arrhythmia, or with persistent the ECG change, I think we should go to the cath lab as soon as possible. So here, my final slide, the figure here is a summary also from the 2020, the European guideline. You can see here, as I mentioned before, if a patient is diagnosed as a non-ST elevation ACS, and they are sent to the PCI center and they have the very high risk or high risk feature, as I mentioned before, all these patients should send for early PCI, usually within 24 hours. If the patient are really unstable, and we should treat them as fast as we can. If a patient are sent to a non-PCI center with these high-risk features, they should transfer to PCI center for early PCI. So ladies and gentlemen, my conclusion are that the keys to decision-making for the timing of PCI are clinical symptoms and signs and the ECG manifestation. As I mentioned before, immediate PCI usually means PCI within less than 2 hours for those with very high-risk patients, as I listed here. And the early PCI is also necessary for patients with very prominent ECG ischemia change or any ST elevation on the ECG. Thank you for your kind attention.
Thank you for Professor Lee's excellent talk, and enjoy your summary very clearly. So any question from our panelists?
I have one question. In your country, for high-risk non-STEMI patients, do you perform invasive strategy within 24 hours as recommended in AC guideline? Because in Thailand, most of the government hospital, we cannot perform the invasive strategy within 24 hours due to the available of the cath lab.
Okay. In Taiwan, usually the non-STEMI patient will receive the coronary angiograph, usually I think maybe within 24 to 48 hours in most hospitals in Taiwan. However, for those, as I mentioned, for those very unstable patients, in very, very high-risk patients, like just I mentioned that if the patient have unstable hemodynamics, in patient with acute heart failure or any appearance the ventricular tachyarrhythmias, I think most doctors here in Taiwan will perform the PCI usually within hours, just like we treat the STEMI. The problem here in Taiwan, I think it's the, we cannot say it's a misdiagnosis. It's the posterior MI or left main MI. Because for those patients, when they come to the emergency room, the emergency physicians usually only look at the ST depression and diagnose them as a non-STEMI. However, sometimes, as I mentioned, for those posterior MI, they are STEMI. They are true posterior STEMI. And also for the ST elevation in AVR, they are sometimes very critical left main disease. So I think the problem here in Taiwan is those two types of patients. We need to be more careful for those ECG manifestations and to treat them as early as possible.
One more quick question, please. Do you pre-treat with P2Y12 inhibitor, or you give the P2Y12 after CAG?
Right now, the common clinical practice right now in Taiwan is loading the aspirin and the P2Y12 inhibitor, usually in the emergency room before sending to cath lab. Before we have prasugrel, prasugrel was introduced in Taiwan in the end of 2018. So the introduction of prasugrel to Taiwan become a problem for Taiwan right now, as we know that usually you have to use the prasugrel if the patient really need a PCI in the cath lab. So right now in Taiwan, we are discussing about the timing of loading the P2Y12 inhibitor. And as we know that in the 2020 European guideline this year, right now, preloading of the P2Y12 inhibitor before CAG now become a class 3. Class 3, that's a contraindication right now in the European guideline. So that is against the common practice right now in Taiwan. So right now, I think the cardiologists here right now are discussing how we should adapt to the new data here. But so far as the clopidogrel and the ticagrelor right now in Taiwan for all those ACS patients, this P2Y12 inhibitor are loaded in the emergency room before sending to cath lab. That's a very common practice here in Taiwan.
Actually, it's also the same practice in Singapore, and they are actually upstream loaded. The point by EAC and thought leaders like Gilles Montelescott is that 50% of this patient that you preload actually should end up with a CABG option. That's why a lot of these patients get preloaded with a delay to complete revascularization. And that forms one rationale why they suggest loading on table, especially if you can get the invasive approach within 24 hours and cover with low molecular weight instead. But I think it's still up for discussion. I think there are pros and cons. And I think in Singapore, we're still not ready to change our standard practice as yet, away from preloading. Especially in Asia, there's still a sort of like preference for a non-invasive PCI approach rather than CABG many times. In Singapore, also just to add on to this very great lecture by Prof. Li Yiheng, is that we incorporate the left main ECG diagnostic criteria as a criteria for activating acute cath lab for acute PCI. So the ED are well aware and trained to recognize the left main equivalent ECG, and that forms one criteria for activating cath lab on top of ongoing chest pain with dynamic ECG changes. So what most of you have emphasized in your criteria forms part of our extended indication for ED direct activation on top of pure ST elevation in mice.
Right.
If I may, can I ask one question? You mentioned shock. What do you think of in the real shock cases, the ACS, they are really high mortality rate? Do you bring them just to the cath lab, or do you intervene with shock therapy, mechanical support device, and before actually cath lab? What are your thoughts on that in Taiwan?
Yeah, that is an excellent question. Usually, I think the condition depends on the different cardiologist in charge of the patient, and also depend on the availability of those life-saving equipment like the ECMO or the IABP in different hospital. I think in most major medical centers in Taiwan, usually for all those patients with ACS and the signs of cardiogenic shock, we are put on the IABP first. Sometimes in the CCU, and also sometimes because under the fluoroscope, it will be much safer, sometimes in the cath lab. So we send the patient to the cath lab, we put on IABP first, and we perform the CAG and the PCI then. However, for ECMO, it's a different situation. So usually in my hospital, you know, if you put the ECMO in the CCU, then you need to transfer to cath lab. That will be a very big job. So usually for ECMO, usually we put in the cath lab at the same time if a patient is really need an ECMO. So that's a different condition we have there.
In Hong Kong, is there any comments about this piece?
Yeah, in terms of hemodynamic support, we usually do it in the cath lab for reason that it's better to do it under fluoroscopy. I think most of the time we transfer the patient, activate the cath lab. If the patient's hemodynamic is deteriorating, or we just give a bolus of inotropes and then rush the patient to the cath lab, and then do the whatever IBP or ECMO in the cath lab. That is our usual practice. I think an exceptional case are those patients who present with cardiac arrest. So sometimes patients present cardiac arrest and the cath lab is not immediately available. And on very rare occasion, I recall in some case we perform bedside ECMO to support the patient and then take the patient to cath lab. But those are the exceptional scenarios.
Okay, any other questions from the panel for Prof. Lee? If not, I greatly enjoyed this lecture, but I think critical ischemia in ACS, the mortality rate, if not handled properly, is much higher than STEMIs, as we all know. The problem is that currently it's still a black box, and most of these cases are multi-vessel disease or very critical ischemia in LV impact patients. Especially this subgroup usually are also more elderly. So making the correct decision key to push them to cath lab early is a good point. If you are bringing to the cath lab early, and as especially this group of patients, I don't know the correct answer about preloading to that. I think most times what interventionists try to do and what the surgeons are shying away is acute bypass. So they still would ask you to stabilize the patient in whatever mode with some form of mechanical support that you can. So in a sense, I'm still in favor of front loading even this group of patients before coming to cath lab. But again, open to discussion. Yeah, I think it's very difficult to individualize, unfortunately. So it has to be as a system-based approach, either preload or not preload on table after cath. So I think still worthwhile discussing. I think great, we covered 3 fantastic topics. We'll move on to the last lecture by Dr. Sui Kin Lam, who's going to talk to us about specific therapeutic strategies for acute MI during COVID-19 pandemic. Kin Lam.
Yes. I'm sorry. Do you see my screen?
Yes, it's full screen now. Please go ahead.
Okay, good. First of all, thank you very much for having me in this forum, and thanks for asking me to share on this topic of therapeutic strategy during the COVID pandemic. So first of all, why special strategy? Or I would say better to say is why alternative strategy? The reason is that the COVID, we all know, affects not only our health, our social life, our economy, but it also attacks our hospital system and also our AMI pathway. If you look at the AMI pathway with this STEMI pathway as the prototype, we know that there are two key components, and that is the availability of cardiac cath lab and the timeliness of activation. Both of these will be affected by COVID. Moreover, there is a component that is missing in the classic AMI pathway, but which is important in the COVID pandemic, and that is the infectious risk to other staff and other patients. So that's the reason that we have to have a new strategy or a new pathway. To do so, each center have to look into their own situation. The first two basic issues to look at is the cath lab manpower issue and also the cath lab operation issue. Manpower may be affected because we know some of our staff may be deployed to other clinical area, and even some of our staff may be sick. Cath lab operation may be affected both because of the manpower and also because, as we heard from some of our colleagues, especially from European, the cath lab may have been changed to clinical area or even ICU. But of course, these are the extreme scenario. Most of the time, our cath lab is still running. And that being the case, the next issues that we are going to look into is whether our cath lab is prepared to take COVID cases, and also whether there is any policy governing the workflow of COVID cases. For this, I would say that the situation for each lab is different. So for the sake of discussion today, I will describe our situation both as sharing and also as illustration of how an AMI pathway needs to be tailor-made. So first, for preparedness of cath lab, back in the SARS era, Hong Kong is a place that is badly hit by SARS. At that time, we reported our experience in preparing our cath lab for SARS and possible for subsequent epidemic, and which is still applicable to this COVID pandemic. At that time, we broadly classified the preparedness into 3 levels. The level 1 and the level 3 is not so relevant to today's talk, meaning the PPE and some of the administrative measures. So what is relevant to AMI pathway is the level 2, or what we call the environment or engineering control. In particular, is whether the cath lab has a negative pressure system. In the era of SARS, we managed to modify our cath lab from a positive pressure system to a negative pressure system transiently using some external equipment. And after SARS, in our paper, we asked for our cardiology community to revamp the ventilation system in the cath lab so as to prepare for another challenge, another SARS or other future epidemic. A few years after the SARS, we have renovated our cath lab and we did install a negative pressure system in our cath lab. However, unfortunately, and embarrassed to say, this doesn't help us much in this COVID pandemic. The reason is that our negative pressure system and our positive pressure system share some common component. And during this COVID epidemic, when we asked our engineer and our infectious control team to revisit our setup, they consider it unsafe for us to shift between negative and positive pressure. And we cannot afford to let one of our labs to stay in negative pressure just for the COVID case. So the message to convey is that each lab definitely has to look into their own situation. So after that, then we have to revisit any policy for the COVID case. What we are referring to is we know that there are infectious risks to our patient and to our staff. So we have to look into whether there is any policy governing the workflow for confirmed case and also for probable case. And for this, I would say that the policy may also be in turn be affected by the government policy in dealing with the COVID epidemic itself. If we look at the epidemic response, after an epidemic is emerged and before the epidemic is eliminated, the management at the society level may include containment, control, and mitigation. Containment means to stop the spreading. Control and mitigation means to reduce the impact on the society if control of spreading is not successful. In Hong Kong, I would say that we focus very much on containment. Our government put a lot of resources in case contact, in contact tracing, and also in quarantine of close contact. I just share with you some impression. Just a few weeks ago, one of the hotels in Hong Kong has got 8 staff confirmed positive for COVID. The health authority ordered a close down of the hotel. All 300 of the hotel staff are sent to quarantine. So this illustrates how meticulous our government is in dealing with this COVID epidemic, in trying to contain the infection. And this stringent control or meticulous measure is extrapolated to the hospital setting because we would like to put every effort to prevent hospital outbreak. Especially we have the sad experience of SARS 17 years ago. So the result is that we have very stringent and clear-cut policy. Confirmed COVID case cannot be transferred to cath lab. And for probable case, we are allowed to transfer the patient to cath lab, but need rule out COVID rule out before doing so. And then the next question for us clinicians is which of our patients needs rule out? And what is the expected time delay that we are facing? For the first question, fortunately, we have a clear-cut definition of which patient require a rule out. The list is long, the list is expanding and is changing in the past few months or half year, starting from patients with symptom, chest symptom, fever, to special group, for example, inbound traveler. And recently, what is added is for any patient, even if they are asymptomatic, if they have epidemiological linkage to some of the clusters of the positive case, then they also require this rule out. Just give you an example. So sometimes 1 or 2 months ago, when we have a small outbreak, at that time, the epidemiological high-risk group includes all people who are living in a certain district in Hong Kong, and also even include taxi driver, just because some of the taxi driver are confirmed COVID positive. So the message is that we have to prepare for a certain proportion of our patients that require rule out before going to the cath lab. And that being the case, we have to know the turnaround time. I'm sorry that some of you may not be able to read this in Chinese, but the message is very clear. It's very simple, I would say. This is the timetable of the COVID test in our hospital. So 6 cycles a day with a well-defined collection time for specimen and also time for reporting. The point is that we have to understand exactly what time delay we will be expecting if we are facing a patient that require COVID rule out. So having gone through all this, then we know that some of our patients will unavoidably require a delay if we transfer those patients to the cath lab. And at this point, I think it's time for us to recall or recap some of our old but classic data, which indicated that the benefit of primary PCI over fibrinolytic will be lost if the time delay for PCI is beyond somewhat around 60 minutes or at most 120 minutes. It is for this group of patients that we have to go for alternative strategy. As mentioned before, as long as the patient fall into the the time frame, then it is better for us to go for fibrinolytic, provided the patient is eligible, say absence of contraindication. And after fibrinolytic, of course, we kept the other piece of data as also mentioned by the previous speaker. We know that the pharmacoinvasive strategy, the result is favorable. So after fibrinolytic, what we should do is to bring the patient back to the cath lab, either for rescue PCI or for routine PCI within 24 hours. But to add to this guideline is after the COVID test result is available. So that illustrates how we should tailor-make our AMI pathway according to the own situation that we are facing. If we look at the other authorities' recommendation, there are several recommended pathway that is published. These are very good reference to guide our clinical decision. But I would say that, again, this does not take into account the situation that every center is facing. So we still have to modify all this workflow. Take an example. This is a position statement from ACC and Skype. They recommend, they emphasize primary PCI for all patients, including the COVID positive patient. And for this patient transfer to cath lab, they advocate a dedicated COVID-19 cath lab. And also both positive case or probable case can be performed in this cath lab. So again, it depends on whether in the local setting, whether this is feasible. Take another example. This is the white paper by the Journal of AHA. They classify the ACS patient, AMI patient by risk. For those patients with low risk, for this guideline, if the patient is positive, then they advocate fibrinolytic therapy instead of primary PCI. But if the patient belongs to high risk, again, they opt for primary PCI invasive strategy. This is reasonable, but again, it depends on whether individual center fit into this practice. So as illustration, sometimes we have to modify the AMI pathway, and this is just an example that applies to our own setting based on what I have discussed. So for patient with STEMI, if that patient is confirmed COVID positive case, then we go for fibrinolytic and antithrombotic treatment if there is contraindication, plus or minus hemodynamic support. If the patient is not COVID positive, then we ask if the patient fulfill our well-defined criteria for COVID rule. If not, then we go for primary PCI. If yes, then we have to see if the patient is fibrinolytic eligible. If the patient is fibrinolytic eligible, we go for fibrinolytic. Then we bring the patient back to the cath lab as part of the pharmacoinvasive treatment after the COVID test was confirmed negative. In case the patient is not fibrinolytic eligible, then we give antithrombotic treatment plus or minus hemodynamic support for the time being, and then rush to the cath lab after COVID test is negative. And in the meantime, on some occasion, we may liaise with our microbiologists and the lab for special arrangement for urgent COVID tests beyond the 6 standard cycles of COVID testing that I've talked about. So to summarize, COVID attacks AMI pathway, in particular primary PCI. Every center should develop its own special strategy. The decision is based on whether the cath lab operation and manpower is affected, whether the cath lab is prepared in handling COVID positive case, and whether there is any policy involved considering the infectious risk to staff and other patients, and also what time frame do we expect in terms of delay. Fibrinolytic followed by pharmacoinvasive approach should be incorporated in AMI pathway for selected patients when primary PCI could not be performed in timely manner. Thank you very much.
Thank you. Thank you for Dr. Che's talk. And any questions from our panelists? In Taiwan, just mentioned previously by Professor Lee, because in Taiwan, COVID-19 is very limited. Right now, the confirmed cases, only more than 500 cases up to date. So the cardiologists in Taiwan, we do not perform thrombolytic therapy between January to May this year. And 9 hospitals, the cardiologists just wear the PPE and perform primary PCI. So how about in other area? So we'll share in the experience in Thailand.
I think our protocol in cath lab is quite the same in Hong Kong. We encourage the non-PCI center to use the thrombolysis if they cannot refer the patient in a timely manner. And if we would like to if they would like to refer the case to our cath lab, they should confirm the COVID test to be negative before they refer the case to our cath lab. But in case that we have the STEMI patients in our emergency department, our treatment of choice is still primary PCI, which we have our own protocol that we would perform the PCI by the younger interventionist, because you know that if the patient with the age of more than 50 years old, the prognosis may be worse than the younger patient. So in our cath lab, if we have a COVID positive patient and we have to do the PCI, it will perform by younger interventionists.
Is it some kind of discrimination? Discrimination
so.
of age.
How about the situation in Singapore, Jack?
Yeah, so I'm glad to hear I belong to the young group. So I still have to do for COVID patients. I a few observations. I enjoyed the talk by Kin Lam. I thought this was a very, I think in our experience sharing in Asia, this is quite a reasonable approach. We also do not have a negative pressure cath lab in Singapore. All cath labs are either neutral or positive pressure. The only cath lab across the region that has negative pressure is in Dubai, in the UAE, where they can build a separate cath lab that is negative pressure. So you're not alone there. I think it's quite similar. A few observations. One is that we did have a similar protocol in Singapore, thinking that in COVID positive patients, we might have to employ a thrombolysis approach. But since COVID started, Singapore, like Taiwan, Thailand, and Hong Kong experienced fairly low numbers, so our experience are limited. And all our patients have had PCIs in COVID suspected, and 1 or 2 COVID positive patients, and none had thrombolysis actually. And increasingly, after I look at the published evidence coming out of countries like Italy, Lombardo, and Spain, is that we have to be a bit careful about the STEMI mimics in the COVID-19 patients who are sick. Those with right heart dilatation failure, with SC elevation inferior leads, or what they call stress cardiomyopathy cases without occlusive lesions. And if you thrombolyze them without defining coronary anatomy, sometimes it can be risky for the patients as well. But I think our numbers in these countries are not huge enough to see those type of cases. For us, actually, I think what we have functioned so far is that ED cases, they fulfill what is called a ARI criteria. We function on full PPE when we do the case. We ask people to leave the environment in the OR so that the case is triaged by security, and we do the swab retrospectively. We do not delay, we do not thrombolyze. So we just do it on full PPE for this group of patients, and we have not changed our practice. So we, as best as possible, try to achieve the door-to-balloon time that's the same, guideline-directed therapy as per same, and we don't try to adjust based on whether it's suspected positive, convalescent, or whatnot COVID cases. We hope that in doing so, we have better outcome for patients, we better define the anatomy. We don't have enough experience to say that there's a big proportion of in situ thrombosis cases for COVID-19. So we may have one case that may be related to COVID-19 with spontaneous thrombi, but we in general do not have that experience in a cath lab. I wonder whether the rest have treated COVID positive patients who we think is not a plug rupture physiology.
Okay. Any other comments or share the experience?
I think as your experience, either Jack or others. So for our center, COVID positive is even more easier to determine. So policy dictate that we cannot do the case, or if your center is allow you to do the case, then it's okay. You do all the precautions. So how do you deal with the so-called probable case? What is your threshold to define those patients as probable? And would you wait for the COVID test first before you move the patient to cath lab, just like our protocol, or you would just do the case, do the test, and then in retrospect, then you know if the patient is positive? What is your practice?
So for us, for probable STEMIs, we do them first with full PPE, then wait for the swab to come back. For the more stable ACS and STEMIs, we swab first and wait for result. So, but for the urgent cases through ED that is a STEMI, we function as per STEMI, but there are some borderline contact history, travel history earlier on, or ARS symptoms, we function as a probable or possible, and we do full PPE when we do the case. But we don't wait for any result.
Right.
In Taiwan, if you have the suspected cases, we should perform as the confirmed cases, the same. But in our experience, the 9 hospital perform primary PCI for suspected cases with COVID-19. All patients turn out to be negative cases.
Right.
No wearing PPE, because right now in Taiwan, the COVID-19 cases is very great.
That's our experience as well, where I would say 99% of suspected cases has come back negative for us. So we don't try to limit the access to care because the positive rate is very, very low. That's for Singapore, I must say. The other thing I want to ask, let people know is that if the patient is truly very sick, hemodynamic unstable, and you think they may run in trouble in the cath lab, and they suspect or positive, we have asked them to be intubated before they come up to the positive pressure cath lab, just in case they turn sick and need emergency intubation.
Okay, thank you. If no questions, I think today's our APSC crowd is very well organized by Professor Jack Tan and Dr. Chashiri from Thailand just talked about thrombolysis or primary PCI for STEMI patients. And Hui Chin talked about capillary only or complete revascularization in STEMI patients. Professor Lee in Taiwan talked about the early, immediate, or delayed PCI for acute non-STEMI patients. And finally, Dr. Tri Kim Nen and talk about the therapeutic strategy during the COVID-19 pandemic era. I think through the discussion and the all around Asian Pacific region, we can share our experience. And in the COVID-19 pandemic days, we just face how to help our patients. I think this symposium APSC crowd is well organized and helped by the program director, Professor Junli Lin. Professor Junli Lin, will you say hello to us? Okay, thank you. Well organized. I think this is a very successful meeting. And I think we can learn about through the webinar education to help the doctors in Asia Pacific area. Thank you, everyone. Thank you.
Thank you, everyone.
Thank you.